the July shared learning webinar and then the evaluation at the end. So just starting out, we'll go ahead and get going. So what I'd like to do is have, I'll just go ahead and call out the name of everybody. If you could please go ahead and list your organization. I know a lot of us know each other by now, but it's always a good reminder because you come together once a month, so kind of hard to remember where everybody's from. But Michelle, I'm going to start with you. If you could talk about your name and your role and your organization.
Sure. So I'm Michelle Sullivan. I am the Chief Quality and Compliance Officer at Yakima Neighborhood Health.
Thank you. We'll go on to Stacy.
Good afternoon, everyone. My name is Stacy George at Community Health of Central Washington, just down the street from Yakima Neighborhood Health. And I am the Director for Quality, Population Health, and Utilization Review.
Thanks, Stacy. And Roseanne, how about you next?
And I'm RN clinic manager at the primary care and rural Providence.
Thanks, Roseanne. And next we'll do Kim.
Hi, my name is Kim Emery, and I am from Dayton, Washington, Columbia County Health System, and I am the Director of Clinic Services there.
Thanks, Kim. And Mike.
Hi, Mike Vetron with Yakima Neighborhood Health Services. I'm the Director of Strategic Innovations.
Thank you, Mike. Rachel.
Hi, I'm Rachel, Population Health Manager for Cadlick and Walla Walla, St. Mary's, and yep, that's the whole story.
And thanks, Rachel. We're going to hear from Rachel today, so I will provide another introduction for her later on. Sarah.
Yep, my name is Sarah. I am a nurse care navigator at Lourdes.
Thanks, Sarah. Yesenia.
Hi, everyone. My name is Yesenia, or Yesi, Health Equity Coordinator at Cadlick.
Perfect. And let's see, I thought I saw another great, is there anyone else from Greater Health Now here today? Okay, we just have Amy Smith, and she's the one that helps us get coordinated and get emails out and invitations out. So we're thankful for all that she does for us on a regular basis. And so that's where you see Amy from, that's Amy from Greater Health Now. So thanks, Amy. So I wanted to go on and provide, so there's some things going on statewide that I want to update everyone on. I'm kind of excited about it. We'll see what comes to fruition, but I'm going to switch to a different screen to share. So bear with me just a moment. Okay, can everybody see the slide that says primary care transformation? I see Michelle nodding your head. Thanks, Michelle. So basically, I have an update from some things going on, particularly with Healthcare Authority on the primary care transformation model. The first thing I wanted to do was just provide a background. I know with all of these acronyms, things get muddy and confusing. So I wanted to just kind of level set a bit and go back to, okay, how did this get started? What is our part in this? And what are we looking at moving forward from what we know today? So back in 2022, the primary care transformation model came out, and we all look at that model when we have the document that's, I think we call it a guide, that has the criteria for each of the 10 accountabilities in it. That was developed with a group of stakeholders over time, and that was well before 2022. There was inclusion of providers is particularly working together, and also there was a group of payers working together. The goal was alignment of some of the payment methodologies and some of the clinic metrics for quality, to align that to make things a little less miserable for clinics, I think, particularly. And we would also, like the stakeholders, another stakeholder that I hope I don't confuse you when I talk about is this long name called the Washington Multi-Payer Collaborative. That's a group of individuals from provider organizations as well as payer organizations that have been meeting together for a series of meetings. We've just finished a series of 6 meetings, and the goal of that was kind of to come together to say, what supports could practices use from payers to get some of this work done, the transformation work in primary care. So they've been a stakeholder for a while, and I know that prior to the 6 meetings that there was work that had been done to develop some of these ideas around the transformation model and around payer advanced payment model structures. So they've been a stakeholder in this for many years. And also other separate individual committees with payers and providers have been stakeholders in this. How did we get involved in this? And as far as Greater Health Now? Greater Health Now learned about PCTM, what was going on at the state level with the Healthcare Authority. And we knew that it aligned with a lot of the work that we had already been doing with healthcare providers, primary care providers, but those of you participated that are on the call, most of you participated in the practice transformation efforts that we did with Waiver One for the Medicaid demonstration project. So we wanted to continue to build on that work because we saw such great gains. And so we thought this is a great opportunity to continue with the primary care providers and keep doing some of this transformation work and hopefully offer some support and technical assistance through the PCTM pilot. So I'm going to pause here and say, does that all make sense to you? Do you have any questions about it? A lot of words, a lot of acronyms. Okay, sounds like you've got it. So we're going to go ahead and hopefully advance. So now that we have all of those older acronyms together, we have a new one. So the Healthcare Authority has been working and they've been asking for our input actually as doing this pilot. I know Michelle and I are both sitting on the Washington Multi-Payer Collaborative Learning Cohort, and we get to hear about what things are being thought of and kind of weigh in on things. But the primary care transformation model, PCTM as we've been calling it, has been transitioned, and it's being called the Primary Care Practice Recognition Program. So I'm going to let that compute for a minute. And if we think about the words there, recognition program. So when we think about that, we've been talking about certification early on at level 1, level 2, or level 3 of PCTM. So it would help to remember that as we jump to this new branding or name of the primary care practice recognition program. So, you know, recognizing clinics that are participating in this and showing competency or demonstrating competency in the various accountabilities. And being recognized by that. So it makes sense. I wish we didn't have the name change, but we do. And that name change, Primary Care Recognition Program, is part of, here comes another one, the Washington Primary Care Transformation Initiative. And while it's, you know, a lot of the same words, the initiative encompasses not only the recognition program, but has also some other components incorporating things that the payer group have come up with as part of this package of a primary care transformation initiative. And we'll get into a little more detail about that in just a few slides. But I wanted to say, take a deep breath and know the accountabilities, criterias, and levels are the same. That it didn't change. So what we've been working on, what we've been trying to work towards in many cases of being able to demonstrate competency, those are just exactly the same. The scoring system is the same. The level 1, 2, and 3 is the same, but it's just a name change. The accountabilities and the practice recognition program tie to payment models and the PCTI. PCTI is Primary Care Transformation Initiative. So this package together, the accountabilities tie to the practice recognition program. And there's payment models. I haven't seen them yet, and it will be very helpful to see how they tie, but we know that with the work we're doing is important. I know that you who are participating see the value in them for our patients that we serve. So the good news here in all of these words is that the Washington State Healthcare Authority is moving forward with the plan to roll out the PCPR, or Primary Care Practice Recognition Program, statewide. So we've kind of been wondering if that was going to happen. As we embarked upon our pilot, we learned about making care primary from the CMS Innovation Centers and thought it was going to just kind of meld together and become one and the same. But latest word is that this Washington State Healthcare Authority is moving forward with the plan to roll out this individual PCPR statewide. So I hope that's good news for you. The work that you're doing is already meaningful outside of this news, but B, this is great because the work that you've been doing is preparing you for recognition in the statewide program. So I'm going to pause again. Any questions on this information? Okay. Good job taking all that in. So what are the outcomes of PCPR? So there are some stated outcomes that have come out, and we at Greater Health Now have incorporated them into a document. There's a document that will soon be available on the Greater Health Now website. At the top of the page, it'll say Greater Health Now Accountable Community of Health pilots the Washington Primary Care Practice Recognition Program. And you can view the document. It kind of covers the things that we're talking about here today. It talks about, well, how did Greater Health Now get involved? You know, what are we doing with this pilot? What's the importance in the future? So the intended outcomes from the HCA for the recognition program is, this is the first one of 4 that are stated, is to provide transparency of the capabilities of primary care providers and broader care system. So if you think about like all the people that are involved in primary care kind of structure, reimbursement, and things statewide, there's a lot of different entities. So by getting some alignment and having this concrete method of demonstrating competency as a clinic in this model, this recognition program, you're able to concretely demonstrate your capability of doing this work. A lot of you are doing the work, and we're working hard on finding outcomes to demonstrate showing improvements on the work that you've been doing. So that's, you know, intentional for the recognition program to have it like kind of specific to Washington State. This is how Washington State is showing what our primary care clinics are doing and with the things that they've accomplished in transitioning or transforming practices toward these goals that are sometimes very difficult to achieve. A second outcome of the program, the recognition process, establishes eligibility criteria for providers to participate in different payment models, aligning incentives with quality care delivery and encouraging providers to enhance their services. So, you know, a lot of you have been doing this work and kind of saying, I don't see an end result. We're still in this fee-for-service model. We keep talking about moving forward, and many of you have been able to move forward and have value-based care contracts in place. But some of you haven't seen that as much. So this recognition program, that one of the outcomes, the intended outcomes, is you can be eligible for different payment models, and hopefully it'll make that easier with, like, when you're talking to a payer to say, hey, we are recognized at level 2 or level 3, and that's like there's a whole lot of information that's conveyed in just that one statement. So it makes the language of what you're capable of a little easier to have. This one is prioritizing payer support. So the third outcome of the recognition process, helping payers prioritize the support they provide to primary care providers, ensuring targeted assistance and resources to enhance healthcare delivery and outcomes. This one's good news to me. I like seeing this, and you know, particularly being able to be part of the multi-payer learning collaborative. I got to hear and see the payers from across the state that are involved in payment, to say they want to collaborate with some of the things that we're doing in transforming primary care. They really do, and I think because they have their own things that they're trying to accomplish or deliverables that they need to show, that's not going to happen without hand-in-hand collaboration with the clinics that are doing the frontline work with patients. And so, you know, right now, in my perception, there's a lot of things that it feels like we're trying to do as clinics or providers, and then we're being given some information from payers, and we don't really know what their goals are that they're trying to accomplish, why they ask some of the questions they do, or want some of the information, data information. But this, I'm hoping, you know, this is going to help us move better to collaborate. And we may see that coming, you know, some opportunities to be present with payers as we continue in this pilot and some of our future shared learning webinars. So I particularly like provide support, you know, so some of the things that have happened in the committee that Michelle and I have been participating on is they're trying to come up, ask us questions on, like, what do you need? How can we help? And so those things have been, we've been trying to answer. And so more to come, and it'll be interesting to see how this all plays out moving forward. Providers, so another intentional outcome of having this recognition program is that providers can use the recognition process as a mechanism to request transformation funding, enabling them to implement innovative practices and technologies that improve patient care and overall health outcomes. So some of us, you know, have been meeting and working together and looking at these outcomes and going, oh, it's so much work, you know, to try to find the discrete data field, or to try to implement, I don't know, like we're having trouble in some clinics about the shared decision making or some of those things. So because we have this construct, this model with the accountabilities and criteria, can actually delineate, well, you were a stakeholder in developing the accountabilities and criteria, but we're having trouble with this, so do you see any way that you can help us so that we can achieve these together? So that would have been the fourth outcome. So some news of late is that the 8 Washington health plans have crafted a memorandum of understanding that outlines their commitment to align with each other and transform the way in which primary care is delivered and supported in Washington. So this would be a dream, right? If you didn't have different deliverables to bring to different payers and just have more of the same requests of information. So you're not doing different data pools depending on who's asking for it. So it'll be exciting. It's not public information at this time of exactly what is in this memorandum of understanding, outlining alignment, but we are looking forward to getting more information very soon. And so there is an event at the Capitol that's scheduled to celebrate the signing of the MOU by the payer group. And this will feature remarks from state and federal officials, primary care providers, health insurance purchasers, and plans who are party to the MOU. So going public with what has been agreed upon by payers. So we will soon, I believe July 9th is the date of this event. And looking forward to getting more specific information, and I will certainly share it with the pilot, everyone that's participating in this pilot. So I'm stopping there and I'm going to ask for any comments or questions at this time. Okay, well, hopefully that was clear so that you don't have any questions. And then what happens, for these shared learning webinars is we do post on the Greater Health Now website the meeting recording and also the slide decks that are part of this. So let me go back to other. Okay. So, Rachel, are you ready out there?
Yes, thank you.
I want to introduce Rachel Inman, who's been along with us during these shared learning webinars and meetings. And Rachel is the manager of population health, quality, and value-based payment contracts for both Catholic clinics and Providence Medical Group. So she's working with Rasan and team to get some of these population health, quality, and value-based contract, all of this information shared between both organizations. So I am going to stop sharing and go ahead and I think you'll be able to share, Rachel, if you can figure it out. We'll give you a minute to do that.
Okay. You can see my screen?
I can.
Okay. I apologize. I was trying to make this a pretty PowerPoint, but we're all in healthcare. We know that some of these slides are a little plain, but I really wanted to show you guys the assistive and auxiliary devices toolkit that we put into our clinics here at Cadlick. Just share the supplies that are in there and a little bit how we use them. a little bit of the why. You know, the Americans with Disabilities Act requires all medical providers to ask patients if they need assistive and auxiliary devices and to provide them free of charge. And we want to offer patients with disabilities assistive devices or equipment so that we can make sure they're getting the same quality of care that we provide for those patients without disabilities. So this toolkit was designed for hearing, vision, and language. We have some statistics here on deaf and hard of hearing. About 2 to 3 children per 1,000 are born with some hearing loss in one or both ears, and 90% of those are born to hearing parents. About 15% of American adults report some trouble hearing. I know for me, if I'm in a noisy restaurant or a loud place and multiple people are trying to talk to me, I would say I have some trouble hearing then. About 100,000 people in the US are functionally deaf. More than half of those are over age 65, and about 500,000 comprise the deaf community and use sign language. And we're here in the Tri-Cities where there are only 5 certified ASL interpreters in the Tri-Cities. Trying to get in-person interpreters for ASL is difficult. For vision, and this one close to home for me, my father has macular degeneration. He has started to lose some vision. He's now going in, you know, getting shots in his eyes. They're trying to prevent that from worsening. So this one hits close to home. We have about 10 million Americans who are blind or visually impaired, 5.5 million seniors. Over the next 30 years, with the those baby boomers aging, they think this will double the current number of blind or visually impaired Americans. Of those that are blind, just 1% are born without sight. Most people lose their vision later in life due to macular degeneration, glaucoma, diabetes. Macular degeneration affects about 13 million Americans, and there are almost 100,000 blind or visually impaired school-age children in the US. So we know these patients are coming in to see our providers. How can we help them? So we've got these little toolkits. There's one in every clinic. I was trying to find a picture to show that these are small plastic storage totes. These aren't, you know, these aren't the large ones. They're like the shoebox sized ones. So we've got one or two in every clinic, depending on how big they are, what they need. They include magnifiers, both globe and page magnifiers, pocket talkers with headphones. So those are microphone type devices, neck loops for those that have hearing aids with a telecoil, signature guides, dry erase boards, communication alert cards, the ASL chart, and then an assessment tool for the staff, and some pictures of these things. We do have remote video interpreting available in our clinic, so they all have a tablet that they can bring in and connect to, I believe it's on-demand interpreter services. There are phones available that can amplify or do the relay phones. Here's a picture of the pocket talker, kind of what that looks like. Dry erase boards, communication cards, and ASL chart. And for low vision, we've got the page magnifier, the smaller globe magnifier, and the signature guides. We also have these communication cards that can go back with the patient. So it can go on, you know, on the room of the door and with the patient chart, really just letting the next staff member that takes the patient know this patient has vision and or hearing loss, and then places where they can check mark, you know, they read Braille or they just need magnification. They need a hearing aid or they need sign language. These are very helpful. We have language cards in the kits, a few emergency communication signs for ASL. And then I apologize, I was trying to get pictures of these out in one of the clinics and I was not taking them at a very good angle, but a language identification chart, so patient, can point to the language that they speak. And I really like this tool that we have for the staff just to help assess the patients and visitors, and then, what to do if they say yes. So would it help if my speech was amplified? We can offer them the pocket talker that they can put on. Do you use sign language? Just kind of the questions that they have that they can ask. And it's just a list of all of those supplies in there. I know that I spent some time, I started working as a medical assistant in our clinic, so I spent some time in pediatrics. I can tell you a personal experience there. There was this family, they came in, I knew them, they came and saw our provider regularly. And it wasn't until maybe the 5th time I was rooming them, and I was asking a question directly to the child, that the mother spoke up and said, "Oh, he's deaf, he can't hear you." I roomed this patient 4 times, just talking away, no assistance, none of these things, without you ever even knowing that this child could not hear what I was saying. They had no opportunity to speak up or add anything into their the care that they were getting, or the things that we were discussing. So I really love this idea that we're asking right there at the front desk. We're asking as we register you as a patient, do you have any of these needs? After spending some time in pediatrics, I went to our geriatric clinic and spent a year there. And I'll tell you, the patients appreciated these tools so much. I use the pocket talker is probably the thing that I use the most. And, when you're talking to someone that's struggling to hear you, and then they put the pocket talker on, you could just see the joy that it brought them, being able to communicate and really hear what they're saying. So I know I found this very helpful. I hope this is helpful to you all. Does anybody have any questions?
I do. I love this. I just really appreciate you showing us. So can you go back to the slide that showed how you ask? More like the scripting slide, I think it was. Yeah. Yes.
I will say I did reach out and ask the department that put these toolkits together if I could have, copies of Word documents, so I can send those to you when I get them, Laurel.
Okay. Well, it just brought to mind, this is such good information. It looks like it's laminated. Is it inside the kit with the tools?
Yes, I think most clinics, the front desk has pulled it out and it sits up there at the front desk with them.
Okay. So what is the training? When is this addressed to train people on the kit and how to use it?
We did a training when we rolled it out for everyone. I think we just did a recorded lunch training. You could go back and watch it when you could. And then as we hire on new folks, we walk them through it. There wasn't, I don't think we had any competency assessments or anything.
That's where my mind was going. Yeah.
But yes, yep. Once we start talking about it, I'm like, oh, we did not assess competency after that training.
Because that helps me pay attention if I go, I'm going to have competency training coming up. It's like there's a new level of listening.
Yeah.
And it's not, people don't not listen on purpose. It's just you have so many things going on that you're like, yeah, hurry up and finish so that I can move on because I have a patient to room right now. Anyway, I really appreciate this in particular because sometimes we develop, get a team together to develop such great ideas, and then it kind of dies with whoever spearheaded that. But having this integrate into, I don't know, annual CBT computer-based training or annual competencies, as part of the staff competencies that you do annually. Those couple of things that make sense to me to keep it integrated because it's so good. It's such good, such a good idea for how to do it. the- yeah, the second question I had was, is how is it documented into the EMR? I mean, is the EMR already flagged that you have a patient that has low vision?
We're on Epic, and there's, when you're registering the patient, there's places to mark if they have any, vision, hearing, language needs. So it does.
Okay. Okay. Perfect.
And we do ask that we document the use of these within the chart note, you know, patient was given a pocket
Okay.
talker.
Awesome. I'll let anyone else that might have thought of a question have an opportunity. Okay. And the competence or the area of accountability was the health literacy area for our, you have to learn the new name, primary care practice recognition program. The criteria is 9.3C, and it says practice has explicit approach to accommodating patients with low vision or hearing. So I check you off on this, Rachel.
Do you guys
So-
have these, Roseanne, in Walla Walla?
No, we do not. We don't have translators. We have to use the translator pads. We do the sign language. We ask these questions, but we don't have the tools. And I know this was shared with me a while ago. I need someone to help me focus on getting all the stuff, and I mean, you have to purchase these things. So then I got to figure out, where do I buy them? How do I get them? There's
Oh,
lots of steps to just doing it. I mean, I got the packet, but that's as far as I got.
That's a good
So,
point, Roseanne. One of the things that I had wanted to, and I apologize, I just wasn't able to connect with the department that puts these together, was I did want to have a list of, you know, brand names and maybe ordering information. When I send out the Word documents that I get, I can send that out, and then Roseanne, I can touch base with you and help you if you'd like any help getting these out.
Yeah, that'd be great. I think that, I don't know if it was, one of my caregivers actually was in a clinic, and it might have been at Cadillac, but there was like this, it was kind of like, whatever they, computer on wheel, workstation on wheels, but it might have been the translator thing, but it was on wheels, and it was something, and then they thought it was the coolest thing. Everything was on this little mobile cart thing, and I'm like, oh yeah, carts, hundreds and hundreds of dollars. I can't afford that. But I'm like, great idea. But I just think those are the things that people are actually seeing and they like, and how do we share it? How do we make it so each area can have something like it within their budget or however? I think that's a great thing. I thought it was really cool when I saw this kit at two. I just said,
yeah, Rachel, can you go up to that slide showing the items that are in it? I think you had a link. I'm a visual person, but.
Yeah.
Oh, okay.
The low vision devices, and then the deaf or hard of hearing. I mean, we don't have an interpreter inside the kit. They wouldn't fit in those little plastic boxes.
it must have been on the cart.
Yeah.
Yeah. I think one of the things about my role is like to demystify what's being asked in some of these criteria. And this is great to have help, you know, for someone to show, hey, this is what we're doing. So I really appreciate that. And then I'm just thinking, you know, of people that I know that, you know, as they're, you know, aging, they pretend to hear you and they smile and nod. And so I'm really thinking it's like, wow, when you look at the neck, what is it called? Neck coil? Is that what you called it, Rachel?
Yeah.
Amplifier?
The pocket talker, yes.
Pocket talker. Man, that seems invaluable because it'd be like, well, we have this if you want, I mean, it's available, you know, so you could actually hear everything that your physician is saying to you. It would seem invaluable, you know, to have available in that clinic. So cool.
I agree. I'll ask what twice, but then I just smile and nod if I don't hear you.
Of course. I mean, we are all like suffering from being too busy and you do what you can, but this is such a great way to have it all like at your fingertips. So, and then the phones are probably just available at the desk or
Yes,
something. Yeah.
Cool. And like in Walla Walla, we don't have phones in each exam room. There's not a phone in an exam room, so you'd have to use the pocket talkers. And at the desk, they're so low compared to where the patient is. The phone won't even reach the patient either. So I think that's going to be, the pocket talker thing, I think is a really cool thing, and how to make it work.
Mm-hmm. Yeah, and sometimes something is simple, like, we just do what we can. The dry erase boards, I know was working with a patient not too long ago, and in one of my volunteer role, and she was hard of hearing, and she just had a dry erase board that was really simple to clear, like you just press a button. I think it was a child's toy, but we were using it and she could just press it and clear. Then you could write what you had to say and clear it quick. And then she could write what she had to say back. And at least we were communicating, which was otherwise, it's just paper, I guess, would be the only way. And so some of these things, I mean, even if you can't get the full gamut, if you can get some pieces of this together, it would be helpful. And just to raise the awareness of the staff. So, all right. Thank you so much.
We have a few CADLIC specific pieces, but I think some of the more, there's only one phone per clinic, or some of the more expensive items. It's like, call us ahead of time when you have that patient scheduled and we'll bring it over to you. And I saw someone asked if the pocket talkers got lost frequently, and I haven't heard that. And I just randomly stopped by a clinic yesterday, said, can I see your toolkit, and snap some pictures, and their pocket talker was in there. So,
oh, good.
There's at least, and that was the senior clinic. So where I would assume they're using it really the most.
Really nice. Thanks for preparing this, Rachel. Very, very thankful. I love these kinds of things, we need some things that are not so complicated to be able to do.
And such a good call out to say sometimes, I think I was telling you this last time, it's just stuff that we're doing and I don't realize, oh, that's a shared decision-making tool, or, oh, that's that's one of these things that fits in this criteria.
Oh yeah. I know these,
so
the fancy words, they just makes you think, it's what are we talking about? I can either it's like kind of overwhelming, like I can never do that, or it's like you don't know what they're talking about. So yeah, I just hope that we can continue to have some of this like kind of basic, it's not that it's just doable, but really important things. I think if it were me and I couldn't hear every time I went to the doctor, that would be really sad because you'd miss so much. So okay. All right, well, I will go ahead and go back to the last bit of things that we have. So our next shared learning webinar is coming up on July 25th at 1, and then this is longer. What we're going to do next time is we are going to combine Greater Health Now has a learning collaborative that they do periodically. I'm not sure the cadence of it, but we've been talking together and another one of the criteria I wanted to try to help people with is getting those contractual relationships with community-based organizations. So I'm pretty excited in working with Greater Health Now staff about what we've been able to conceptualize and kind of pull together for our next, it's our next shared learning collaborative, but this is, you'll see, hopefully you have already gotten an email from Amy Smith from Greater Health Now that says there's a learning collaborative, and the title is Cross-Sector Communication contractual partnerships between healthcare and community-based organizations. So what you'll have to do, there's a link and you'll need to register for that so that you can attend. And I wanted to just give you an idea of who we have coming for speakers. So first of all, some of the Greater Health Now staff will be giving us an update in regards to the upcoming hub model and how it can help to strengthen these partners between healthcare organizations and community-based organizations. And then we'll move on. We have Kittitas County Health Network will be, and I know some of you are either part of that or at least familiar with it. So they are going to present about their collaborations between healthcare partners and community-based organizations in the area. So we also, there's 3 presenters. So Sue Logson and Sasha Burkhart, I hope I said that right. And Nicole, correct me, I thought I saw you hop on. And then Greg Abel from Comprehensive Health is also going to be part of that Kittitas County Health Network. So they have a really great collaboration going on to discuss some of those complex care patients. And there's some things that we can see to kind of help us bolster our efforts to get some more of those community-based collaborations going on. The next speaker and other speaker that's going to be there, his name's, and I'm not sure if I'm saying it right, but it's Mark Homowiki, and he's a lawyer. He's a leader of the National Center for Complex Health and Social Needs at the Camden Coalition over on the East Coast in New Jersey. He's going to share the legal considerations for complying with HIPAA and 42 CFR Part 2 and contractual relationships. So super excited to have him come or actually be present virtually and talk to us, debunking some of those myths about HIPAA. So some of the things that I've already learned from him have been very helpful and provide clarity into being in compliance with both HIPAA and 42 CFR Part 2. That is all going to happen coming up here next month. So hopefully you guys will get that email and be able to register. And please, please, please invite your any of the people within your organizations or even within the community-based organizations that you are in communication with. So we're looking forward to that. So last of all, hopefully those of you who are here could please, I think Amy has dropped in the chat the survey or the evaluation or feedback for us for the shared learning webinar today. So I really appreciate anything you can offer here as far as if this is useful or not, or what kind of topics you might want to see in the future, or any comments you have. So it's super quick, 2 questions and a place for comments. If you could complete that for us, I would greatly appreciate it. So that's pretty much it. I get to give you, I think, a few minutes back of your day. What is it? 7 minutes. Okay.
Thanks, Laurel.
You're welcome. Good to see you, Michelle. Thank you.
Thank you. This was great.
Oh, good. I'm glad, Kim. Bye-bye.
Bye.